Okay, I think we're live, or so I hope we're live. If not, I am simply just talking to myself. Anyway, it's that third Thursday of the month, and on the third Thursday, as you know, we do our quiz. So I am doing our quiz, and I have about a dozen cases for you. Let's get started. Patient with elevated liver functions. You can see there's lots of neovascularity in the right lobe of the liver. The liver texture is irregular. When you look at the MIP, you really get a feel about how irregular the vessels are, right? You see all of this beating. This is not going to be a benign lesion. It's not the look of hemangioma. It's not a cyst. It's not infection. This is going to be a cancer. And when you see a large liver mass, textural changes, lots of neovascularity, you're basically dealing with a primary tumor. There are a few rare sarcomas. This is not the look of a cholangiocarcinoma. This is the look of a likely hepatoma. Here it is on the venous phase. You can see multiple masses in the left lobe as well as the right lobe. There's some ascites present, and this was a hepatoma. Very nice case. And again, the importance of dual phase imaging and the importance of the neovascularity on the arterial phase. A liver mass. You have a cystic lesion with a rim and calcification. There's some soft tissue and cystic components. The lesion is well defined. And then you start looking and you see the lesion hanging off, but they look like multiple cystic lesions. So now it's not just one cyst, but it's multiple cysts, and it's one lesion, and there's some calcification present. Here it is on the coronal view. There's the complex cystic lesion. Yes, you could say, could it be a simple cyst? No, that's not what a simple cyst looks like. Could be cystic metastasis. But again, all of what I would best describe as daughter cyst, and the calcification makes that unlikely. Patient had no known malignancy. You don't see anything else. Here's on the arterial phase. There was no neovascularity, like in the first patient. What am I thinking? Well, I could think about a cystic tumor. Biliary cystadenoma can have septations, but that doesn't usually calcify. Again, clinical history, the patient was from a country far, far away from Baltimore, and this was hydatid cysts. Hydatid cysts, multiple daughter cysts, can have rim calcification, can be somewhat tricky, and again, the key is to think about the possibility. I know many of you who are on this call or will listen later are from areas of the world where hydatid cysts are endemic. So you probably see far more of them than I do. Chest pain, non-contrast scans only. There's a calcified mass in the patient's left atrium. What gives you a calcified mass? Yes, thrombus is a consideration, but this is a really large mass. Left atrium, usually you see thrombus with catheters or right atrium SVC. You got to be thinking, what could this be? Could it be tumor? So you got to say tumor. What tumors calcify? Left atrium, calcified mass. You got to be thinking of myxoma. Myxomas occur in both right and left atrium. The right atrial ones theoretically calcify more than the left, but this is a wonderful case of a calcified left atrial mass that was a myxoma. Again, remember that. See a calcified mass, think about thrombi, think about Mets, think about other tumors, but in the atrium, you gotta go with myxoma. Incidental findings, cystic lesion, talar pancreas, rim enhancement. You can go through a differential from mucinous cystic neoplasms to serous cystadenomas. If the patient was young, you would think about a Spen tumor as well. Could it be old trauma with a hematoma that had rim-like calcification? I guess theoretically that's the case, but there was no history of that. So now I'm dealing with a cystic lesion, rim calcification, nicely shown on the cinematic rendering. And what was it? If I told you the patient was young, I would have said that it was a Spen tumor. This patient was 45, female, which is the perfect age for MCNs. MCNs often will calcify. They typically do not have dilated ducts. The appearance of calcification is variable, but this was a good example. Fever. Now, the thing about the abdomen, you'll notice, look at the pancreas. Where is the pancreas? You can see where it should be, but it's all fat, right? So now you say, what replaces the entire pancreas? There's a few unusual entities, but the one that you need to be thinking about, you will get when I show you the next image, and you see the extensive inflammation in the lung with bronchiectasis, lung inflammation, really bad bronchiectasis, elevation of the hilum, and replacement of the pancreas by fat. What are you thinking? You're thinking cystic fibrosis. And again, we did AI on this, and AI cannot find the pancreas. But that's perfect because I'm not really seeing the pancreas. I'm seeing the outline of the fatty replacement and where the gland should be. Really nice case. Right lower quadrant pain. Well, if you look, there's something enhancing in the region of the cecum. You have an enhancing lesion in the cecum. It could be adenocarcinoma, they usually don't enhance. Tumors of the colon that enhance, you can think about a GIST tumor. That location also makes you think about a carcinoid tumor. Enhancing lesion in the cecum. And then you look, there are some nodes present or nodules, and you think about something in the mesentery, which is enhancing, and something in bowel, TI or cecum. Then you got to say the PET is positive as well. Well, guess what? And by the way, yes, you see some liver mets. What are we dealing with? We're dealing with a carcinoid tumor. Common location, cecum, terminal ileum, mesenteric masses, liver metastasis. Just a terrific case. Pelvic mass. Well, what do I see here? I see a pericardial effusion. I see what looks like a small myelolipoma in the right adrenal gland. I see what looks like a mass in the right lower quadrant, but it's calcified, and with the patient's small kidneys, this is a transplant. But what about this mass in the left lung? Could it be a tumor? What is that? Well, let's go further. The bones are coarse. Maybe it's from the renal osteodystrophy. Then there's a soft tissue mass. So now I'm saying end-stage renal disease, coarse trabeculation to bone, mass in the left lower lung, paraspinal, mass in the pelvis, presacral. What are we dealing with? Well, we're dealing with extramedullary hematopoiesis. This is a patient with bony changes, the mass in the lung. This was extramedullary hematopoiesis in a patient with thalassemia. The mass in the left lower lung was extramedullary hematopoiesis, as well as the more typical appearance in the presacral space. Pancreatic mass, cystic lesion, rim calcification. There is enhancement. When you see enhancement of a cystic lesion, you could think about a serous cystadenoma or even a mucinous tumor, but the ones that typically, to me, with calcification and enhancement, I got to be thinking about a neuroendocrine tumor. So what about a neuroendocrine tumor of the pancreas? That would indeed be a good thought. Enhancing rim calcification, cystic components. You got to go in that direction. And this was a cystic neuroendocrine tumor with faint calcification. Really nice case. What about this one? Mass and tail of pancreas, the wall is thickened. Again, location and age would be important. Location would be a good place for MCN. Could be a serous cystadenoma. Could be a neuroendocrine tumor like the prior case. It could be a cystic tumor or a pseudocyst which maybe was infected. There's atrophy of the distal gland and mild duct dilatation. So thickening, cystic, body of the pancreas. I tell you the patient's 50-ish. You're pushing yourself to go with an MCN, which this indeed was. The thickening of the wall was of concern, but this ended up being low-grade dysplasia upon resection. Most people will recommend resection of MCNs of the pancreas. Elevated LFTs. There's a mass in the right lobe. It's infiltrating the IVC, right? There. There's lung metastasis. You go further, large mass, dome of liver, growing into IVC and up into the right atrium. What could it be? It could be a primary tumor, it could be Mets. Mets typically don't involve the IVC, primary tumors do. It's not very vascular, not the best appearance, but could be a cholangio. More commonly invading would be hepatoma. That's a good thought. Metastasis, another possibility. Other unusual tumors. Again, mass in liver, vascularity will vary, but direct invasion of the IVC, lung metastasis, this is a hepatoma invading the IVC. Very nice case. Another case, elevated LFTs, multiple liver and splenic lesions. What could this be? It could be metastasis. It could be mets from many different tumors. Tumors that give lung and liver. We can talk about things like lymphoma. We can talk about things like melanoma. There are many things, renal cell, but they're usually vascular. Lung cancer can be both. But this is extensive liver and extensive lung. The organs are a little bit big, but again, extensive tumor. And when you look at all of the images, you basically are going through the differential of lung versus other tumor versus lymphoma. Here it is on the cinematic, very nicely seen. One thing you always need to consider when you think about lymphoma and multi-organ involvement is also, particularly with liver and spleen, is also to think about melanoma. And this was metastatic melanoma, a really good example. And that's it. Those are your dozen cases. I hope you learned something. I hope you enjoyed the cases. And I hope you have a great day. And with that, see you next time.